Good morning, and thank you for joining us for Grand Rounds. Today's speaker is Dr. Ishan Roy. He's currently in the final year of the Physician Scientist Training Program in Physical Medicine and Rehabilitation at the McGaugh Medical Center of Northwestern University and the Shirley AbilityLab. He received his MD and PhD at the Medical College of Wisconsin through the NIH-sponsored Medical Scientist Training Program. His research interests are in cancer rehabilitation, metabolism, systemic inflammation, and muscle wasting diseases. His clinical interests include fatigue, cachexia, and musculoskeletal issues in cancer patients. After completing his training program this June, he will stay at Shirley AbilityLab as a physician scientist faculty member to establish a lab dedicated to translational work in cancer rehabilitation. Please enter any questions for Dr. Roy in the Zoom chat, and he will answer them at the end of this presentation. Dr. Roy?
Okay, so once again, thanks again for having me to speak at this Grand Rounds. I think it's a great opportunity for us to kind of establish some collaborations between the rehab hospital where I'm training and will be a faculty member and the Cancer Center. I'll be joining the team of Dr. Gail Spill, Dr. Sam Chapar, and Dr. Priya Matre. All of us are specializing in cancer rehabilitation to some degree, and I'll be having an outpatient practice for the most part, and so we can talk a little bit at the end if anyone has any questions on the types of patients I might see. Today, I'll be talking about 3 different stories that are related to both cancer rehabilitation and my specific interest in cachexia. But before we do that, I don't really have any disclosures, but some of the basic science work was funded by the Innovative Catalyst Grant Program at our rehab hospital. So the main objectives for everyone today are first to understand how cachexia impacts cancer patients. Second, to understand the current barriers to treating cachexia in cancer patients and other populations that potentially have cachexia. And then third, hopefully everyone after listening to this talk will be able to describe how focusing on function as a primary outcome can potentially help develop new cachexia therapies and identify the key populations that are affected by cachexia. So my goal as a physician scientist is really to try and identify the physiologic mechanisms that drive functional decline in patients with complex diseases such as cancer. I think everyone understands that cachexia, or cancer rather, leads to intermediate conditions that can lead to morbidity and debility, and that's both from the cancer and its treatment. And so cancer rehab clinicians and scientists, their goal is to focus on those intermediate mechanisms. And some of the classic diagnoses that fit into that box include lymphedema, musculoskeletal complaints, pain, deconditioning. But my goal is to more precisely define those diagnoses with actual pathophysiologic mechanisms so that we have greater knowledge about this specific process. So cachexia in particular has been of interest to me because I think it's a candidate mediator of function in cancer patients. Colloquially, I think people know it as wasting disease, which is really progressive deterioration of muscle and fat tissue. It's a systemic syndrome driven by inflammation. Really, though, it's associated with pronounced weight loss, symptoms such as fatigue, and then even progressive functional decline. So in the cancer population, it actually has an overall prevalence of about 50%. But that prevalence is much higher in certain cancers like GI, pancreatic, and lung cancers. And 30% of all cancer-related deaths can be tied to specific processes that are within the cachexia syndrome. On the other hand, I think it's a little bit misleading to focus on just one specific cancer type when we're talking about cachexia. It is true that there's high prevalence of weight loss in the GI cancers, in pancreatic cancer, and lung cancer. But even if we look at prostate cancer, the total prostate cancer population, the prevalence of weight loss is quite high. And so then if you take a more systems-based approach to looking at the incidence of cachexia, For example, this data is from Henry Ford in solid tumor patients. You can see that the distribution of cachexia in the total cancer population reflects pretty much the distribution of cancer overall. Similarly, if you look at the distribution of cachexia in by stage in cancer patients, you can see that the largest fraction is actually local disease, and then the distribution really reflects the overall distribution of staging in cancer patients. And so early stage patients with high performance statuses get cachexia, and we know that if they have cachexia at those states, they do worse overall. And they respond more poorly to therapies, they complete fewer chemotherapy cycles, and they have more therapy-related side effects. One of the important things to know about cachexia is it's not the same thing as sarcopenia. The two terms are part of the larger umbrella of muscle wasting disorders. But from a mechanistic standpoint, cachexia is an inflammatory process that's associated with chronic disease, such as cancer, but also COPD, chronic heart failure, chronic infections such as HIV, chronic kidney disease. All of these populations have a significant fraction of patients who have cachexia. Sarcopenia, on the other hand, is classically tied to aging mechanisms. It's not typically in a high inflammatory state, and more recent studies have really defined primary sarcopenia as a neuromuscular problem. So the last part I think that's important to realize about cachexia is that muscle is really the outcome of this syndrome by which we recognize it clinically, but in reality, the mechanisms that that are underlying this particular syndrome span quite a few other organ systems, including the cardiovascular system, sex endocrine organs, the pancreas, bone, the GI tract, the liver, and the brain. And so it's important to realize that a lot of the same inflammatory mechanisms that are impacting muscle and fat are doing things outside of that as well. So progress in treating cachexia has really stalled. There are no current FDA-approved therapies specifically that improve mortality, quality of life, or function related to cachexia. And there have been failures in clinical trials at both early and late phases. So the cachexia field has recognized several specific knowledge gaps at the basic science level that they think impede successful translation. And so these include the lack of translationally relevant animal models, the lack of studies that work on non-pharmaceutical measures and more multimodal approaches, and then the lack of biomarkers or outcome measures that have been validated to be truly translationally relevant and more patient-centered in this population. So I think that's where a rehabilitation science approach can bring a new perspective to the cachexia field. And so really what this means is taking a greater emphasis on the overall progressive functional decline aspect of cachexia as opposed to specifically the muscle aspects. And so those of us in the rehabilitation science field use function as our primary outcome across multiple domains, and that includes muscle or motor or cognitive domains, but also just looking at functional independence and factors influencing that. As clinicians in the rehabilitation world, we're experienced in interventions that include exercise, nutrition, impairment-driven therapies such as PT, OT, speech, neuropsychology, and providing precise prescriptions for different mechanisms of disease. And then the last part is that we're fairly comfortable in the multidisciplinary setting of trying to combine these in very specific ways for complex diseases. So, I kind of have created a pipeline for myself in my career of how do we get to implementing new therapies for those cancer patients who have cachexia. And it starts with defining the scope of the problem, finding new physiologic targets for rehabilitation and pharmaceutical interventions, testing some of those things against those new targets, and then trying to combine them together into a multimodal intervention. And so today's talk, I'm going to tell three short stories that address different parts of this pipeline. So the first story that I'll be talking about is developing preclinical animal models of cachexia. The second story will look at what is the current role of rehabilitation interventions in cachexia. And then the third will shift to looking at some of the emerging cancer populations and how cachexia is specifically impacting them. So let's go to our first story, which is finding physiologic targets for rehabilitation. And that really starts with trying to establish a preclinical model of cachexia. And so this work I've done under the mentorship of Dr. Rick Lieber, who's a muscle biologist and the chief scientific officer at Shirley and AbilityLab. So we basically said, are there current animal models of cachexia out there that are amenable to preclinical high throughput testing of rehabilitation interventions? And so we set 5 criteria out for this particular problem. And basically what they were was, first, that these animal models had to express human relevant disease in terms of the genotype and phenotype of the tumor. That there had to be systemic involvement of the cachexia that we were seeing, including it being in an immune competent environment, and there being some evidence of extramuscular involvement as we see in people. And then the third and fourth were that there had to be longitudinal changes in muscle and physical function. So what does that mean? Well, as I'll get into in a little bit, the vast majority of cancer models out there die rather quickly, rather rapidly, just from the tumor burden. And so the systemic physiologic effects of the cancer are not necessarily observable in those timeframes. And then the last part was that the model had to be relatively low cost if it's going to be of value as a preclinical model for high throughput rapid testing. So there's about 7 or 8 models of cachexia that are well published on out there. And so if we look at how they do against these 5 criteria, you'll see right away none of them meet all 5 criteria. In fact, none of them meet even 4 out of 5 criteria. And they really kind of fall into 2 buckets. Either these animal models were pretty short in survival, like a maximum of about 3 weeks. And that's a significant number because if we're going to talk about rehabilitating muscle hypertrophy in all mammals, whether it's rodents or people, takes about 6 to 8 weeks to happen. And so a model that falls short of that timeline is not particularly helpful in terms of outcomes. And then the second bucket that these models fell into was that they often expressed an obscure cancer genotype or phenotype, and so then have limited translational value. Nevertheless, if we look at all of these, one model kind of stood out to us. So that was the KPC orthotopic model, as having human relevant disease with systemic involvement and being relatively low cost, but not meeting that longitudinal requirement. So we thought, how can we potentially adapt this model without changing the integrity of it in terms of cancer? So this model is derived from transgenic mouse, the gold standard transgenic mouse model of pancreatic cancer, the KPC model developed by Dave Tuvison. And so then you take cells from those animals and then reimplant them in a new mouse in its pancreas. And so then you can have this model that reflects human disease, but you have control over the starting time. We thought, are there variables that we can try to manipulate, such as cell lines or cell dosing or vehicle substrates, that would allow us to extend the survival of the animals while maintaining progressive muscle loss and function loss? So if we were successful in doing this, we could call this an FPANC model. So let's look at some of the data for generating this. So first, if we test multiple cell lines, and here's a few of them, we can see that one particular cell line, the 122s, had extended survival compared to the others. And then second, if we look at different vehicle substrates, such as saline versus matrigel, we can see that phosphate buffered saline led to extended survival. And then third, if we do a careful dose titration of these cells, starting from 1 million cells, which is kind of the typical injection dose in most models, all the way down to just 10, we can see that there's a threshold dose about 1,000 or 100, where there's extended survival of these animals, but they do succumb to the tumor eventually. But that number is about at 8 or 9 weeks in terms of median survival. And so that is then amenable to that muscle hypertrophy timeline that we want. If we then plot the size of these tumors against time, we can see that there is, at the FPANC dose in particular, an extended linear phase. of growth. And so that would imply that there's a longer time period for systemic physiology to happen before morbidity occurs in the model. And then if we look at these animals, the tumors of these animals histologically, we can see that they phenotypically express the pancreatic ductal adenocarcinoma, which is the most common type of pancreatic cancer. One of the hallmarks of this cancer is extreme desmoplasia. And so if we do a staining such as trichrome, which looks at collagen in blue, we can see that there's a significant amount of collagen in these tumors. If we look at glycosaminoglycans, which are another stromal component, again, in blue and Alcian blue, again, there's a high amount of that. And then lastly, obviously pancreatic cancer has the capability to metastasize, and we see both liver and lung metastases at the microscopic level in these animals. So now we've established this model where there's this extended survival. The next steps are seeing if there's muscle wasting and what timeline that occurs under, and seeing if there's functional decline, and again, what timeline that occurs under. And so theoretically, whatever that overlap is between the two is the window for testing rehabilitation interventions. Now, to get to the muscle part, we initially collaborated with my former lab at the Medical College of Wisconsin, where they did serial CT imaging on these animals and found progressive decline in muscle volume over time of about 7 weeks. Over here at Northwestern, we've shifted to using MRI so we can more carefully measure muscle and fat. And so those experiments are now ongoing. If we do ex vivo analysis of the tissue in these animals, we looked at multiple different muscle groups and we add them all together, we can see that there's progressive decline in muscle loss over time at the FPANC dose. The muscle group in which that was most sensitive for changes was the quadriceps muscles, and you can see that follows that same pattern. If we plot muscle mass loss over the size of the tumors, there's a linear correlation between the two that's significant. And so this suggests that there is some connection between the degree of muscle loss that's happening and progression of the cancer itself, and that there isn't necessarily an independent mechanism driving this atrophy. Now, if we look at evidence of systemic involvement, first we see that there's loss of cardiac muscle over time as well, and this suggests that there's cardiac cachexia going on, which is kind of a subtype of the cachexia syndrome, not seen in all models. And then if we want to look at some initial evidence that there is systemic inflammation happening, we can just look at the size of the spleens, and we see splenomegaly that occurs over time as well. Now, we measured function a few different ways. Grip strength is used quite frequently in the animal model world, and of course in clinical trials for cachexia as well. And interestingly, at higher doses of the model, or higher doses that we initially tested, we don't see drop in grip strength until about 7 days before the animals succumb to morbidity from the disease. On the other hand, if we go to that lower FPANC dose, now we see that progressive change in function happening over time. So this is kind of interesting and suggests that perhaps this change in grip strength we're seeing, which parallels the progressive change in muscle mass, is actually due potentially to cachexia as opposed to changes in morbidity that lead to behavior changes. But that gets into this larger topic of whether grip strength is really very specific in terms of function in animals or even in people. And so if we have time at the end, I have a few slides in human studies that we've generated that we can talk about that particular topic. So in terms of our animal model, we decided to measure function at a much broader level by collaborating with the Behavioral Phenotyping Core. And there, if we follow the distance explored in an open field environment, we see that the FPANC animals have much lower exploration, and then they also have lower gait speed. We can measure motor endurance through a rotarod assay, and there we see at certain time points that these FPANC animals have much lower endurance. On the other hand, if we try to assess the cognitive behavior of these animals through like a Y maze setup, the animals in the FPANC group compared to the control group have similar rates of error, suggesting that their spatial memory is intact through the model. So ongoing things, as I alluded to, include longitudinal tracking of muscle volume by MRI in parallel to functional analysis. We're also going to be tracking serum markers of inflammation and protein catabolism in parallel to function. And we're in the process of doing more specific histologic analysis of the muscles to try and start to get into what is the mechanism of atrophy in this particular model. So if we look at the 5 criteria that we established, we think the FPANC model meets all 5 of these criteria. And so now what's the next step for us? Now we can start to get into what are the systemic mechanisms that occur all the way from initiation of the cancer and cachexia down to the endpoint of the model, including inflammation, whole body metabolism, trying to understand what are the components of function that are contributing, including muscle versus the central nervous system and the brain. And then once we've started to define those physiologic mechanisms more precisely, then we can target specific exercises and test those in this preclinical setting in a quick way. So for example, we could try to find what is the anti-inflammatory dose of aerobic exercise in a more precise way in this model. We can then also combine that with nutrition that's targeted, or some of the pharmaceuticals that have failed in early clinical trials as single therapies. So let's move to then the second story in the talk today. So this involves looking at the impact of cachexia in our inpatient rehabilitation population. This was done under the guidance of Dr. Prakash Jayabalan, who's a physician scientist in our hospital, focusing on biomarkers of musculoskeletal conditions. So for those of you who don't know, inpatient rehabilitation for cancer patients is a big part of our hospital. Patients who come here, they have significant functional declines. Typically, they were in acute care at Northwestern. And so they require persistent medical monitoring, but have the ability to participate in intensive therapies. And so when they get here, about 3 to 4 hours, 6 out of 7 days a week, they're doing physical therapy, occupational therapy, speech and language therapy. They have access to adaptive equipment training, neuropsychologists, and dietitians. And so the cancer population that we have here is fairly diverse. The largest fraction are CNS tumors, intracranial and spinal cord, but actually a majority of our patients don't have neurologic involvement disease. The biggest fraction there is the hematologic malignancy population, followed by the GI and lung cancer populations as well. So we've established a retrospective database of these patients, extracting data from both Northwestern and our own EDW in an automated and manual way. We collected data from 6 months prior to rehabilitation, so it includes their acute care, but also outpatient care during that time in the cancer center. And then also collected data for 6 months after admission to rehabilitation. The current iteration of this database, there's about 250 patients, over 330 admissions from about 18 months worth of data from 2017 to 18. The factors that we've collected in this database include cancer type, stage, certain sequelae, what happened to these patients during their acute care admissions and why they were admitted to acute care, also things like vitals and labs. For their outcome measures in rehabilitation, we focused on motor and cognitive FIM scores, which I'll explain in just a second, 6-minute walk test, grip strength, their independence after discharge, and then survival for 6 months afterwards as well. So FIM scores are the functional independence measure scale, this is the gold standard for measuring function in the inpatient rehabilitation setting. It's a scale that's 18 items. The items, 13 of them are motor items and 5 of them are cognitive items. Each of those items are scored from 1 through 7 by therapists. And so if you look, for example, at therapy notes, even in the acute care setting, oftentimes what the therapists are documenting fits in line with this scoring system. So how do we go about identifying patients with cachexia in inpatient rehabilitation? Well, one way would be to use the classic weight-based markers. So typically, patients who have greater than 5% weight loss in a 6-month period would meet criteria for cachexia. The threshold is a little bit lower if you have really low BMI. But there's a problem with weight-based markers, and that's that they're typically confounded in a number of different settings, particularly if acute medical issues are going on. And so we first came up with two different groups for separating this out. We decided, are there folks who've had chronic weight loss in the 6 months prior to inpatient rehab? But separate from that, are there patients who've had just rapid weight loss that occurred in the acute care setting? Beyond that, we then looked at specific markers of nutritional status or muscle mass that we typically collect under standard labs in inpatient rehab. And that included low creatinine and low albumin. And we just defined low as below the standard NMH lab threshold. So these are then the 4 markers of cachexia that we decided to follow in our population. So amongst our cancer patients, we see that the incidence of these different markers varies. About 60% of patients have chronic weight loss, a quarter of patients have rapid weight loss, a third of patients have low creatinine, and 2/3 of patients have low albumin. We asked if there are specific subpopulations that we have here that are particularly susceptible to cachexia compared to others. And so here in bold and with the asterisks are the significant associations in univariate screening. And for example, you can see that the intracranial tumor population has lower odds of low albumin. GI population has higher odds of rapid weight loss. The hematologic population has higher odds of chronic weight loss. But if we apply a multivariate model to this group that includes a number of other demographic factors, interestingly, what we find is just the yellow square is the only independent association. So the breast cancer patients have lower odds of chronic weight loss. The other thing to kind of see in this is that there is no consistency really amongst the 4 different markers, suggesting that potentially they have different value in terms of clinical outcomes. Now, if we then look at the acute care factors that for the reasons why these patients were admitted, in a univariate screen, we can see that patients who are admitted for an infection have higher odds of weight loss, while surgery patients have lower odds of chronic weight loss. But then again, if we apply a multivariate model, the only thing that stands out is those patients admitted for non-infectious altered mental status have increased odds of rapid weight loss. The last part was we looked at specific details during their acute care stay. And in this case, we see several factors that lead to increased odds of rapid weight loss and increased odds of low albumin. But with a multivariate model, the only ones that stand out are increased length of stay in acute care leads to increased rapid weight loss. And then steroids lead to decreased odds of low albumin in independent associations. So kind of the takeaways from this were that the 4 different markers aren't identifying necessarily the exact same populations, and that in a multivariate model, the population is relatively diverse. There isn't necessarily one particular group that is at highest risk of cachexia. So the next question was, is there one particular group that is at particular risk of poor functional recovery during inpatient rehabilitation? So we took a number of the factors that popped up in that univariate screen and then compared them to the markers of cachexia. And then we also started including high neutrophil to lymphocyte ratio at the same time. The outcomes that we looked at included motor FIM scores, cognitive FIM scores, 6-minute walk test, and grip strength. And so this is going to be a heat map visualization. So what that means is if there's a black square, there's no statistical association. If the square is green, it means there is a positive functional outcome. If the square is red, then that means there is a negative functional outcome compared to the general cancer rehab population that we have. So let's look at a univariate screen first. So you can see quite a few squares, mostly are red. There's clustering of red around the cachexia markers in particular. And then if we apply a multivariate model to this, the 2 associations that stand out are low creatinine and poor motor outcomes, and low albumin and poor cognitive outcomes. Well, the last thing I'll note is that there was no statistical associations with grip strength, even in the univariate screen. So if we look at functional independence as an outcome in this case, there was about 3 different ways to look at it in this population. We can look at those who discharged to a skilled nursing facility after inpatient rehabilitation rather than going home. We can look at those patients who had to return back to acute care after inpatient rehab, either emergently or for something planned. And then the third category was those patients, among those who go home, there's a fraction that require home-based therapies primarily because they lack the independence to leave their home on a regular basis. And so with that, again, we see several associations. And if we then apply a multivariate model, the ones that are independent include those with recurrent cancer and returning back to acute care, those with low creatinine returning back to acute care, and those who have low albumin having a very high odds of home-based therapies being homebound, in other words. The last outcome that we looked at in terms of this population was how well were these patients potentially recovering their weight during inpatient rehabilitation. And interesting, what we find is that the chronic weight loss patients actually recover a significant amount of their weight back. On the other hand, the low creatinine and low albumin patients lose weight during inpatient rehabilitation. And that stands true in a multivariate analysis that also includes age, the cachexia markers, and the BMI weight loss grading scale. So to kind of summarize what we're seeing here, we don't think there's necessarily one specific subpopulation that is particularly impacted by cachexia that we're seeing in inpatient rehabilitation. There are specific serum markers of protein catabolism that link to poor functional recovery and even poor recovery from weight loss. On the other hand, a more positive way to look at this is that patients who have weight loss as their indicator of cachexia are capable of functional and weight recovery with the interventions that we provide in inpatient rehabilitation. So what's next using this data? So obviously, we'd like to move to a prospective study model where we can do more agnostic biomarker screening, like to follow these patients in the longer term after inpatient rehabilitation. And then third, perhaps the most complex question is how does cancer treatment impact these patients' rehabilitation response? And that's, a very cancer-specific question. And so we really just need a larger sample set to try and address that. And that's something we're thinking about doing, is doubling this data set. And the broader population that we could potentially impact would be the outpatient rehabilitation interventions that we have and how that impacts cachexia. And so we haven't started to address that quite yet. And then the more immediate question would be what's happening to these patients that come to inpatient rehabilitation before that, in terms of what's going on in acute care, were there opportunities potentially for a pre-rehabilitation intervention overall. And so that gets to our third story today, which is understanding the impact of cachexia on emerging populations. And so this work was done with the guidance of Dr. Reem Karmali and also the larger lymphoma group headed by Dr. Leo Gordon. So what do we know about cancer cachexia in the immune therapy population? So if we look at a study from a couple of years ago looking at pembrolizumab in melanoma and lung cancer patients, what they found was that there was a lower likelihood of a complete response to therapy in those patients that had a negative change in albumin, low absolute albumin, or a negative change in their weight. So those authors suggested that cachexia is somehow manipulating the immune response that should happen with immune checkpoint blockade. A subsequent study by folks in Japan who looked at a diversity of immune checkpoint inhibitors and separated out the patients who had cachexia and didn't, found that the high PD-L1 patients who had cachexia were responding pretty much the same as the low PD-L1 patients. And then in those patients who don't have cachexia, the high PD-L1 patients were the ones who were responding as you would expect. So what does that mean potentially for the CAR T cell population that's now emerging? Well, right now, there aren't any clinical studies that have examined that. There are animal models that have, in the early phases of CAR T cell development, that showed cachexia and bone changes depending on what the CAR T target was. More broadly, we know that cachexia is prevalent in the hematologic malignancy population. Dr. Karmali, of course, has published on the aggressive lymphoma population in particular. We also know that this population that gets stem cell transplants and can potentially get graft versus host disease, we know that that is a particular contributor to cachexia, but it's not the only factor in this population. And then if we look at basic science studies, we know that several different types of immune cells are involved in the pathogenesis of cachexia, including macrophages, neutrophils, and CD8 T cells. So Dr. Karmali has established this retrospective database of all the aggressive lymphoma patients at Northwestern that have received CAR T, including the DLBCL population and mantle cell lymphoma population. And through this database, there are factors including weight change, the BMI weight loss grading scale, neutrophil to lymphocyte ratio, CRP, albumin, creatinine, and then even scoring systems like MGPS, which is the Glasgow prognostic score for cachexia, can also be calculated. And these factors have been collected from diagnosis, pre-collection for the CAR T, during the CAR T admission, and then in regular follow-up up to day 360. We, of course, also know the important demographic and cancer pre-CAR T factors in these patients. And so if we combine those two together, then we can look at the relationships in terms of outcomes such as relapse from therapy, responsiveness to therapy, mortality, and function, which we chose to measure by need for rehabilitation services. So with this relatively long timeline, we can do some longitudinal modeling. For example, we can look at weight change over time. And so if we look at weight change in this population and we separate them out by those patients who eventually had relapse versus those who did not in the time frame, and we look at weight change from diagnosis, we see a separation in these two populations, where the relapse population has more negative body weight change throughout the course of the window of study. And that separation is definitely there right from the diagnosis time point, diagnosis to pre-collection time point. However, if we then move up the timeline and just examine the patients from CAR T onwards, we can see, again, there continues to be a progressive negative decline in the weight change of these patients. So cachexia has the ability to potentially impact these patients from early on in the stage of disease all the way through multiple therapies. So if we look then at snapshots in time and try to say, is there particular snapshots in time that we can predict that cachexia would have led to a particularly negative clinical outcome, we can look at odds ratios. And so then if we look at all the different cachexia factors, if we start at the pre-collection phase, what we see is that of all of them, the ones that stand out are a high neutrophil to lymphocyte ratio and body weight loss from diagnosis. Both lead to increased odds of relapse. If we move up the timeline now to the pre-CAR T, just before they get CAR T and are admitted, now we see that increased CRP and high neutrophil to lymphocyte ratio lead to increased odds of 90-day mortality after discharge. And then third, if we move the timeline to after their treatment in the follow-up phase, now we can see that body weight loss from diagnosis or neutrophil to lymphocyte ratio lead to increased odds of relapse and increased odds of 90-day mortality, respectively. So what if we flip this and look at functional outcomes? Again, looking at all of the different factors and seeing if any of them are significant. The two outcomes we looked at were need for any type of rehabilitative service, whether that's home-based PT and OT or inpatient rehabilitation. What we find at the pre-collection phase is that body weight loss from diagnosis or a high BMI to weight loss grading score led to increased odds of either needing any type of rehab service or specifically needing inpatient rehab. If we look at the factors that were collected just before their CAR T admission, now we see that low albumin and body weight loss from diagnosis lead to increased odds of needing rehabilitative services. So much so that actually, if a patient had any body weight loss at all from diagnosis to prior to their CAR T admission, every single one of them needed rehabilitative services after that admission. So let's try and combine some of these observations together from the two different retrospective studies into one table. And so the clinical outcomes, if there's an association with a particular marker, they're in red. Functional outcomes are in yellow, and then orange means there's a combination of the two. The difference between orange and red is not a big contrast. I can see that now. The inflammatory markers at the top, such as neutrophil to lymphocyte ratio and CRP. Nutritional markers are at the bottom, albumin and creatinine, and body weight. is in the middle. And so you can see one particular pattern developing in acute care where the inflammatory markers for sure seem to be connected to clinical outcomes. But then that pattern changes in inpatient rehabilitation. Now, I didn't really comment on neutrophil to lymphocyte ratio in inpatient rehabilitation before, but really we didn't find any significant associations in our population. And I think that's really because the vast majority of these patients come in with very high neutrophil to lymphocyte ratios. And so it's perhaps not that sensitive in this population. On the other hand, if we look at the commonalities, you see that albumin is potentially a marker for functional issues in acute care and both medical and functional issues in inpatient rehabilitation. As I said before, the next steps would be looking at this in the outpatient setting. We have some preliminary data in the CAR-T population looking at that, but really we haven't collected functional outcomes in the outpatient setting yet. So to summarize everything that we talked about today, we can see that there's a high incidence of cachexia in the cancer patients with dramatic functional decline who come to inpatient rehabilitation. There are distinct markers of cachexia that potentially could tie to separate outcomes, clinical versus functional. They may be setting dependent, they may also be cancer dependent. And then the last part is that we have this novel longitudinal model of cancer-associated cachexia. It leads to progressive muscle and functional loss and is expressing translationally relevant cancer. And so this is then the opportunity for us to start testing new ideas. If we go back to that pipeline of getting to implementing novel therapies for this population, I think we can use some of the clinical data to inform future studies. And I think there is a separation in the patterns we see between inflammatory markers and metabolic markers. So we can start to then, in a more agnostic way, ask if certain inflammatory markers versus metabolic markers are biomarkers for medical decline or functional decline at various settings. We can then also ask if any of these markers are good at predicting functional recovery from either exercise or rehabilitation. And then the bigger endeavor that I'll be more immediately starting with is using our animal model to understand what's going on at early phases of cachexia versus late phase, and again, focusing on inflammation versus metabolism as separate targets for exercise, different pharmaceuticals for different nutritional interventions that are targeted, and then combining them all together. So I think we still have just a little bit of time, so I'm gonna go back to that grip strength comment that I made earlier. So one of the issues in the cachexia field at the clinical trial level has been that people suspect that the wrong outcome measures were focused on. And so there are probably successful therapies out there that failed because we weren't looking at the right things. And so I've been talking to some of the lead investigators in the cachexia field who are in discussions with the FDA, and they've realized that one of the linchpin outcomes that was being used over and over again was grip strength. And so grip strength obviously has a lot of data behind it in terms of its connection to mortality and even morbidity in quite a few different populations. But I think the sixth sense that a lot of rehabilitation physicians have had, or clinicians have had, is that grip strength may not be so sensitive in terms of functional decline. And so I went ahead and retrospectively looked at that in our inpatient rehabilitation population because we have such a sensitive marker of functional change in the FIM scores. And we're also collecting grip strength in this population. And so if we look at how the change in grip strength compares to change in motor scores, and then plot that in the different scoring grades for BMI, weight loss combined, what we see is something interesting. At the 0 grade score, so these patients definitely do not have cachexia if you're looking at BMI or weight loss, then we see a significant correlation with grip strength between FIM score and grip strength changes. But if they have any level of cachexia, then there is no significant correlation. So what's a potential different marker that we could use? Well, we do also collect 6-minute walk test, as I mentioned. And so here we see significant associations across the spectrum of this grading scale. So this suggests that perhaps 6-minute walk test would be a potential better marker to use in clinical trials. If we then expand a little bit more and say, okay, what if we looked at any of the 4 different cachexia markers that we looked at in our retrospective study, chronic weight loss, rapid weight loss, or low creatinine, or low albumin, again, now we see significant associations, correlations that are fairly tight in terms of each of these wasting markers and 6-minute walk test changes, but not the case at all in grip strength. And this actually holds up in a multivariate model where if you plug in both of these markers, since they are a little bit dependent. And so with that, I'll take questions. There's a few people I'd like to acknowledge first. Dr. Lieber, again, has been my mentor on the basic science side, Dr. Jayabalan on the clinical science side on rehab, but a number of other folks, including Ben Binder-Markey, were heavily involved with the animal model development. And then on the most recent project, Dr. Karmali has been incredibly helpful. I think many of you know cachexia is a particular interest of hers. Madeline Burkhardt and Gordon Smilnek. So Madeline Burkhardt, many of you know, is the fellow in oncology, and Gordon Smilnek is a medical student, helped with some of the data collection. And so, like I said, I'm happy to take questions. I have my email on the bottom. From a clinical standpoint, I'll be having 3 half days of clinic, and then the rest of my time is protected for research. I'm happy to see any type of patient who you might be interested in referring for rehabilitation services who has cancer. And if you're really even just thinking about rehab services and you have a question, feel free to email me. And I'm happy to work things out. Similar from a research standpoint, if you think that cachexia can fit into your research program, then I'm happy to talk about what that can look like. And so with that, I'll stop sharing my slides and see if there's any questions in the chat. Okay.
Thank you, Ishan. I did have a quick question about in pancreas cancer, we do a lot in terms of neoadjuvant therapy. Because one thing that would be kind of nice is if there's a way we could look at this in the neoadjuvant space, because we'd struggle sort of once the patient gets to Whipple or surgery, and then we sort of have a decline quite rapidly in that setting.
Yeah, I agree. You know, the neoadjuvant therapy window, I think, is actually a really good opportunity to also implement a parallel rehabilitation intervention. So I think if we could recognize this population at the time of diagnosis when they're getting their fine needle biopsy, for example, or their initial CT scans, I think there's an opportunity there to recognize the patient population and then test something simple, whether it's a nutritional intervention that's targeted towards the deficiencies that they have, or something with exercise. I think you're right. That is the window to look at things. I think it's a challenging thing to model potentially in an animal model, but I think there's a lot of clinical data that we could mine and then take serum samples and try to come up with a more agnostic biomarker that's function oriented.
Ishan, this is Sheetal, and I agree with Aparna. I'm sorry I had to jump in and out of this lecture, so I don't know if you covered this, but I agree that I think we oftentimes think of these interventions as interventions or studies, but really there's enough data to show that like this should be part of standard of care, where patients getting neoadjuvant therapy for pancreas cancer, for example, have prehab. And there's an ECOG Akron study, Aparna, I don't know where it is in this population, but if there was a kind of a systematic way that we could work with you and, give the patients what we know they need, and then be able to study the mechanisms by which they're helpful with collecting serum, I think that the program would be interested in that. I'm excited that you stayed here, and we should definitely look at some of this stuff in both the metastatic population, as well as I think survivorship's another area where we have nice cohorts of patients that these studies could be done.
Yeah, I completely agree. And I think to some degree, we have this data. It's just that you have to kind of look carefully through the chart to try and diagnose someone with cachexia. And I think anyone's capable of doing it. It's just that you have to kind of pause and look at that specifically. So it would be pretty easy to retrospectively try and even diagnose this population. And, obviously one of my goals is to look at biomarkers from an agnostic perspective, but I think we have enough right now to say, this population should get some sort of at least rehabilitation evaluation to identify a patient's impairments and then start focusing on those in that neoadjuvant window before things get a lot worse.
One of the really interesting that I'm not sure some people in the division even know as well that we're working on is a high risk oncology model where it's going to use kind of what is that called? What we talked about, which was like machine language learning in order to have a better predictive model for who's at high risk for being hospitalized or coming to the ER. It's something we're working with analytics now to get the variables right in order to identify who is ripe for an intervention to avoid ER and hospitalization. But it will be cool to work with you and get some cachexia variable in there.
Right.
I'll loop you in at some point.
If it's a serum marker, then it's great because that can plug in automatically. If it's a weight-based one, I think it's one that, a nurse could easily do that measurement.
Those are discrete fields already that could be looking at like change in velocity and weight.
Right.
But we just need the right variable. So we'll loop you in.
That'd be great.
I don't know if anybody else has any questions. Thank you, Ishan. We're really excited. I think this will be great for the program.
Thanks so much for the opportunity. And like I said, if anyone has any just general cancer rehab questions on a clinical basis, I'm really happy to talk about it too. And I'm looking forward to working with everybody.